Recall in Lesson 2 that we talked about selectivity of drugs. Examples of alpha-1 receptor agonists with selective activity include phenylephrine. Phenylephrine is an FDA-approved drug that can be used as a decongestant, and it is also used as a vasopressor. It has utility in hypotension, shock, including septic shock. Alpha-2 receptor antagonists. We also identify selective drugs. These include methyldopa, used in hypertension and gestational hypertension, clonidine, a common blood pressure medication that you will see prescribed in the community for treating hypertension. Remember, the downside of clonidine, secondary to its effectiveness as an alpha blocker, it causes orthostatic hypotension. This drug can also be used to treat attention deficit disorder. It has other non-FDA approved indications, which include its use in sleep, post-traumatic stress disorder, anxiety, and hot flashes. Etomidate is often used for sedation in the intensive care unit. It is favored because it does not cause respiratory depression. We also have selective beta receptor drugs. Beta-1 receptor agonists that we spoke about include dobutamine. Dobutamine is important because it is used in cardiogenic shock and heart failure. Beta-2 receptor agonists with selectivity include a number of the bronchodilators that are used for COPD and asthma. Beta-3 receptor agonists, some of those drugs are used in the treatment of overactive bladder and urinary incontinence. Some of the more common non-selective drugs that we see in everyday use include norepinephrine, which is indicated for the treatment of shock and hypotension. It is a very common medication in the ICU. Epinephrine, or adrenaline, is used in the treatment of cardiac arrest, anaphylaxis, and croup. Another drug that we spoke about is dopamine. Dopamine is also indicated for the treatment of hypotension, but it can also be used for the treatment of bradycardia and even in cardiac arrest. Isoprenaline is indicated for treating bradycardia and heart block. What are some adverse effects of adrenergic drugs? The most common side effects that we see are due to changes in heart rate and blood pressure. These selective agonists bind to the alpha-1 receptor. They can lead to hypertension. Certain drugs that bind to the alpha-1 receptor, such as phenylephrine, may cause reflex bradycardia. Drugs that selectively bind to alpha-2 receptors may cause hypotension, dry mouth, and sedation. At higher doses, we see respiratory depression, somnolence, and these effects are most pronounced with clonidine and similar acting drugs. Selective binding to beta-1 receptors can also lead to adverse effects such as tachycardia, palpitations, and hypertension. Tachyarrhythmias and anxiety are not uncommon, and high doses may lead to dangerous arrhythmias. An example of this type of drug would be dobutamine. Beta-2 receptor antagonists can cause tremors, tachycardia, racing heart, and anxiety. Some common examples of this type of drug would be albuterol and salmeterol, two bronchodilators. Non-selective binding to adrenergic receptors can cause different side effects that vary based on the specific agent, as well as the dosage. The common non-selective agonists that we spoke about are norepinephrine, epinephrine, and isoproterenol. Common side effects are tachycardia, hypertension, arrhythmias, palpitations, and anxiety. Norepinephrine is less likely to cause arrhythmias than some of the other pressor medications, probably because it is more alpha-1 receptor selective as compared with beta-1 receptor. What are some contraindications? Alpha-1 receptor agonists are relatively contraindicated in those who have medical conditions such as hypertension, bradycardia, prostatic hypertrophy, and anyone using medications which may also increase blood pressure. Alpha-2 receptor agonists should be used cautiously in anyone who has low blood pressure, especially in geriatric patients who may be at increased risk for falls due to orthostatics and the sedating effects, as well as the hypotensive effects. Beta-1 receptor agonists require caution in patients who have arrhythmias. Beta-2 receptor agonists are relatively contraindicated in patients who have hypokalemia. Norepinephrine, one of the most common pressors, is relatively contraindicated when using certain anesthetics and can induce dangerous arrhythmias. Epinephrine is contraindicated in patients who have closed-angle glaucoma. Monitoring in these patients is very important. In these patients, you must monitor for hypertension as well as potential arrhythmias. Alpha-2 agonists, these patients should be monitored for bradycardia, hypotension, and potential substance abuse. Beta-2 agonists, these patients should be monitored for paradoxical bronchospasm, blood pressure effects, heart rate, and central nervous system effects. Let's look at a drug that has wide use, epinephrine. Epinephrine is direct acting. Its effects include increasing blood pressure, increasing heart rate, relaxation of bronchial smooth muscle, vasoconstriction in the peripheral blood vessels. It can also increase blood glucose, lactic acid, and fatty acids in the blood due to its metabolic effects. It leads to increased leukocyte and increased coagulation. It also inhibits insulin secretion. Remember that epinephrine affects both alpha and beta receptors. At usual doses, the beta effects on the heart and the vascular smooth muscle effects will predominate. Higher doses, however, alpha adrenergic effects will predominate. It is the drug of choice for bronchospasm and laryngeal edema in anaphylaxis. Remember that epinephrine, it is excellent as a cardiac stimulant and its vasoconstrictive effects in cardiac arrest. You may also remember that it is important as a local anesthetic, and let's remember why. It is because of its vasoconstrictive properties. This will limit bleeding in local procedures, so it is very useful in the outpatient setting. The drug may be given intravenously or by inhalation, topically. It is not given PO. That is the exception. It is a physiologic antagonist to histamine, and that is how we get some of its benefits. Individuals who are on beta blockers will need larger doses of epinephrine for effect. Other adrenergics that we want to mention include ephedrine. Ephedrine is a mixed-acting adrenergic drug. It stimulates both alpha and beta receptors. It is longer lasting than epinephrine. Pseudoephedrine is another adrenergic, and it is used for its bronchodilating and nasal decongestant properties. Third, isoproterenol. Isoproterenol is a synthetic catecholamine. It acts on beta-1 and beta-2 receptors, so it stimulates the heart and dilates blood vessels and skeletal muscles and causes bronchodilation. It doesn't have any alpha stimulation. So used in the heart, it may work when pacemakers are not available, and it also may act as a bronchodilator. Nonselective, finally, is a pure alpha adrenergic agonist. It decreases cardiac output and renal perfusion. It has no beta-1 or beta-2 effects. It lasts longer than epinephrine, and it can cause reflex bradycardia, but it has usefulness in ophthalmology. Let's take a look at amphetamine and dextroamphetamine. These drugs are used in ADHD. The trade name, commonly Adderall and Adderall XR. These drugs are Schedule II. They have some risk of dependency. The indications are ADHD. Most commonly, there is also some use in the treatment of narcolepsy. We have immediate release. This is not recommended for children under the age of 3. There is dosing which can be given at weekly intervals. There is also ADHD extended release preparation. This is not approved for children under the age of 6. When this drug is given for narcolepsy, it can be given in divided doses 4 to 6 times a day. The mechanism of action of amphetamine and dextroamphetamine. These drugs are sympathomimetic, and they promote the release of dopamine and norepinephrine from their storage sites and presynaptic terminals. They may also block reuptake of catecholamines by competitive inhibition. The adverse effects include loss of appetite, headache, insomnia, abdominal pain, and weight loss. The warnings include using this drug in cardiovascular disease and cardiomyopathy, mental illness. There is a risk of long-term growth suppression. Seizures may occur, worsening of peripheral vascular disease. There is also an abuse potential, as it is a Schedule II medication, and there are unknown long-term effects on children. Another drug that is similar to amphetamine and dextroamphetamine is under the trade name of Vyvanse. The indications for Vyvanse are also attention deficit disorder, but this medication can be used in binge eating disorder. It is also a Schedule II drug. The mechanism, this is a prodrug of dexamphetamine. Used in ADHD, it is immediate release. It can be used in adults and children older than 6. It is not recommended for children under the age of 6. Caution must be used in patients who have renal impairment. The adverse effects of Vyvanse include anorexia, insomnia, dry mouth, headache, abdominal pain, irritability, and nausea and diarrhea. The warnings include it should not be used with MAOIs. It may cause cardiovascular events. There is a risk of behavioral changes and even psychosis. The next drug is methylphenidate. Methylphenidate goes by many brand names, perhaps most common, Ritalin and Concerta. This is also a Schedule II medication, so there is some risk of dependence. The indications are ADHD and narcolepsy. The dosing is very specific to the diagnosis, so it may vary depending on whether one is treating ADHD or narcolepsy. The mechanism of methylphenidate, this is a mild central nervous system stimulant. It blocks the reuptake of norepinephrine and dopamine into the presynaptic neurons. So it appears to stimulate the cerebral cortex and other subcortical structures similar in that way to amphetamines. The adverse effects are that it may cause insomnia and decrease appetite. The warnings and adverse effects are very similar to the adverse effects and warnings that we discussed with amphetamines. The next group of drugs that we come to is the adrenergic antagonists, or blockers. These drugs act on the skin, the mucosa, the intestines, lungs, kidneys to prevent vasoconstriction. So the effect is dilatation. This is dilatation of the arterioles and the veins, leading to decreased blood pressure. These also cause pupillary constriction. They increase gastric motility, and they may be helpful in the treatment of BPH, or benign prostatic hypertrophy. They may cause or they may activate reflexes that oppose fall in blood pressure, such as fluid retention and increased heart rate. They can prevent alpha-mediated contraction of smooth muscle in non-vascular tissues. Some examples of adrenergic blockers or antagonists include prazosin, tamsulosin, and terazosin. What are some other uses for alpha-1 blocking agents or alpha-1 antagonists? These medications are primarily used in the treatment of hypertension, but they can also be used in benign prostatic hypertrophy and in vasospastic disorders. They may also be used in persistent pulmonary hypertension in newborns. They can be useful in treating pheochromocytoma. With alpha blockers, first dose syncope may occur from hypotension, so it is important to start with the low dose, usually at bedtime. Explain to patients that reflex tachycardia and fluid retention may occur. Alpha adrenergic antagonists bind to A1 and A2 receptors. An example is phentolamine. An alpha-2 antagonist can affect blood pressure. We have some examples of alpha-2 blockers, including clonidine, or catapress, and methyldopa. There are other indications for the adrenergic blockers. These include the treatment of severe pain in cancer. This medication can be administered by the epidural route. There is also some investigational use, and that includes anger management, alcohol withdrawal, postmenopausal hot flashes, and ADHD. There is also some investigational use in opioid withdrawal. What about in the common class of drugs known as the beta-adrenergic blockers or antagonists? These are blood pressures that end in OLOL. Beta blockers prevent receptors from responding to sympathetic nerve impulses, catecholamines, and beta-adrenergic drugs. They prevent the binding of epinephrine and norepinephrine at these receptors. Beta-1 and beta-2 receptors, both found in the heart, may be affected by these types of drugs. What are some uses of common beta blocker drugs? Beta blockers are mainly used for cardiovascular disorders. There is use in angina, cardiac dysrhythmias, high blood pressure, myocardial infarction, and even glaucoma. In glaucoma, beta blockers reduce intraocular pressure by binding to beta-adrenergic receptors in the ciliary body. These drugs decrease the formation of aqueous humor. In angina, beta blockers will decrease myocardial oxygen consumption, decreasing the heart rate. They decrease blood pressure and also contractility. Overall, beta blockers slow conduction both in the SA and AV node. These drugs may also inhibit renin, decreasing cardiac output and decrease sympathetic stimulation. Beta blockers may worsen heart failure because they are negative inotropes, and there is a risk of sudden death. These drugs have been studied because there is also risk of decreased remodeling in heart failure. So overall, beta blockers will do the following. Beta blockers decrease heart rate, they decrease the force of contraction and cardiac output. They slow cardiac conduction. Beta blockers decrease automaticity of the ectopic pacemakers. They decrease renin secretion from the kidneys, and they decrease blood pressure and bronchoconstriction. Beta blockers may lead to less effective metabolism of glucose, and they may result in more pronounced hypoglycemia. Beta blockers cause decreased production of aqueous humor in the eye, and as a result are useful in the treatment of glaucoma. They also cause an increase in very low-density lipoproteins and a decrease in high-density lipoproteins. They result in decreased portal pressure in patients with cirrhosis, When beta blockers are discontinued, this must be done gradually because long-term blockade results in an increase in sensitivity to both epinephrine and norepinephrine, and this can result in severe hypertension. So tapering beta blockers is very important and should take 1 to 2 weeks. How do we use beta blockers in cirrhosis? Propranolol may decrease the incidence of bleeding esophageal varices. Beta blockers used to be contraindicated in heart failure, but now, for many, they are the standard of care. They are known to reduce sudden death. They are often given with ACE inhibitors. So the clear indications for beta blockers include hypertension, angina, and prevention of myocardial infarction. We can also look at the selectivity of beta blockers. We have some beta blockers which are cardioselective. These include acebutolol, atenolol, betaxolol, esmolol, and metoprolol. These drugs lose cardiac selection at the higher doses because most organs have beta-1 and beta-2 receptors. Beta blockers with non-receptor selectivity include nadolol, propranolol, sotalol, and timolol. These medications can cause bronchoconstriction, vasoconstriction, and interfere with glycogenolysis. Some drugs commonly in use have a combination selectivity. These include labetalol and carvedilol, or Coreg. These drugs block alpha-1 to cause vasodilatation and have beta-1 and beta-2 receptors, which will affect the heart and lung. Both alpha and beta properties, however, contribute to the antihypertensive effects. They may cause less bradycardia, but more postural hypertension and less reflux